This is IPE Group 6, and we will be discussing understanding hospice and end-of-life care.
So what is hospice care? Hospice care is a type of palliative care focused on providing comfort to individuals with 6 months or less to live. Hospice care is not centered around curing an illness, but rather a shared decision between the patient, physician, and patient's family to shift from formal treatment to maximizing comfort and prioritizing the patient's quality of life during their final stages. Hospice care is holistic, meaning it not only addresses the medical needs of the patient, but also their physical, social, and emotional needs. This care also extends to the families and loved ones of the patient to ensure their well-being in what can be a very emotional and difficult time. Although there is no formal criteria for determining whether or not a person qualifies for hospice, it is typically considered in cases where an individual is plagued with an incurable illness with a poor prognosis, typically less than 6 months to live, and when there is a large decline in health, whether that be difficulty performing everyday tasks, significant weight loss, or their pain is becoming increasingly harder to control.
Some of the main concerns patients and family face during this stage could be emotional psychological challenges. Facing the end of life can bring up a range of emotions, fear, sadness, and anxiety. Patients may struggle with losing independence while families deal with anticipatory grief. Mental health and emotional support are just as crucial as medical care during this time. Communication and decision-making are also very important. One of the hardest part of this journey is talking about what comes next. Patients and families may avoid conversations about dying, but clear communication helps ensure decisions reflect the patient's values. Last but not least, access and quality of care is also very crucial. Not all hospice cares is created equal. Some areas lack resources or trained professionals. Families worry about pain control, emotional support, and how well their loved ones' individual needs will be met, especially across different cultures and beliefs. These concerns are very real, but with thoughtful planning and compassionate care, they can be addressed to help bring peace and dignity at the end of life.
Okay, now we shall get into how hospice care relates to today's older adult population. Well, as our population continues to age, the need for hospice and palliative care is growing rapidly. We're seeing more patients with multiple chronic illnesses like heart failure, COPD, and dementia that require coordinated, compassionate end-of-life care. This means that hospice services need to be more readily available and better integrated into the care continuum. And unfortunately, not everyone has equal access to hospice services. Racial, ethnic, and socioeconomic disparities continue to play a big role. There's also a gap in cultural competent care, which is essential to providing meaningful support for diverse communities. We need more initiatives that address these barriers. And just to briefly talk about COVID-19, the pandemic, which we'll be talking more about in the next slide, the pandemic really laid bare the fragility of our hospice systems. Isolation policies, while necessary, caused significant emotional harm to patients and their families. Many died alone. At the same time, hospice staff faced burnout and shortages, which deeply affected the quality of care delivered. And too many older adults still don't have documented advanced care plans. The pandemic reminded us how important it is to have these discussions early before a crisis hits. It's crucial that we help patients clarify their goals and values before they reach a critical point in their illness. And next, telehealth became a major lifeline during COVID-19, but for older adults who aren't tech-savvy or don't have access, it created a huge barrier. This digital divide made it harder for many patients to stay connected with their providers and care teams, especially in hospice settings. And now, last but not least, caregivers, often family members, were put under intense pressure during lockdowns. Without respite, care, or additional support, many experience burnouts and emotional fatigue. This burden needs to be recognized and addressed with better resources and backup systems. And we'll talk about that later. Thank you.
During the COVID-19 pandemic, hospice care faced several major challenges. First, access to care was significantly disrupted. Many patients avoided hospitals, and overwhelmed systems made referrals more difficult. Staffing shortages became a serious issue with widespread burnout and exposure risks for frontline workers. Visitor restrictions meant many patients spent their final days isolated from family, while spiritual support services were also limited. The pandemic also worsened existing disparities, especially for marginalized groups without access to reliable technology. Financially, hospices struggled with reduced revenue and rising costs for PPE and infection control. Emotionally, both families and providers experienced grief and moral distress. Families were also unable to say goodbye, and staff were unable to provide care as they normally would. Lastly, rapid policy changes helped in some ways, but created uncertainty that continues to affect hospice care today.
How can we improve end-of-life care in geriatric medicine? First, we can educate healthcare professionals on death in different cultures and religions. We can do this by having regular CME for healthcare professionals to help them understand what different patients of different religions and ethnicities are going through and what special needs they may have. And then we can also have public education to help family members understand end-of-life care and what to expect and decrease fears in obtaining end-of-life care help. Secondly, we could increase research into systemic barriers for minorities and low-income individuals. There is a lack of research into a way to decrease barriers created by policies, paperwork, and insurance for individuals for end-of-life care, and it's been hypothesized that many minorities are less likely to have continuity of care as well as end-of-life care due to these issues. Perhaps hospice can instate programs to assist patients step by step in navigating these bureaucratic processes and ensure regular follow-ups with patients and their support systems. Lastly, we can improve community programs that support and socialize elderly communities. So humans often thrive in familiar and comfortable environments, and programs such as home meal delivery, walking groups, bingo nights, and home care aides can help the elderly remain as long as possible in their own homes. These programs keep the mind active, it allows for regular religious observances, and increases the ability to seek regular care as it can come to them, because navigating public transportation or finding private transportation can often be difficult for having many doctor's appointments and things of that nature. And it also keeps families close together, which can increase happiness and therefore is better for the state of mind of elderly individuals.
Each healthcare worker has a unique role in the care of older adults. The members of a hospice care team can include palliative care specialists, who can be physicians, PAs, and nurses who manage treatment plans for hospice patients. There are also social workers who help coordinate end-of-life planning with family members, hospice aides who assist with activities of daily living, pharmacists who perform medication reconciliation that can lead to safer medication use, and there are various types of therapists who also aid in the care of older adults. Nutritionists can be helpful to recommend foods to maintain the nutritional needs of patients, and chaplains can be available as needed for spiritual guidance. It is important to note that burnout is a common experience for healthcare workers. Burnout can look different for everyone, but it can include loss of motivation, feelings of detachment, or difficulty concentrating. It is important for caregivers to reach out to their support network in times of need.
Yeah, as Grace mentioned earlier, hospice is truly one of those interdisciplinary fields where you need contributions from all different kinds of professionals to make it a smooth and easy experience for the families and the patients themselves. So, for example, if some of the responsibilities of the providers are not met, there can be many drawbacks, and this can ultimately lead to improper grieving and bereavement for a lot of families who might have been blindsided by the lack of care. You can also have a violation of autonomy, which basically, like, some providers may pursue very aggressive treatment, and oftentimes this treatment can result into delayed comfort care. So, that last few, months or whatever, how many months or years they have on their life, it's shortened. And, this always relates to the question of quantity of life or quality of life. And hospice is really truly about quality of life. Of course, there's also legal and ethical consequences because, if someone is not taking care or providing the necessary care, this can obviously cause negligence and can result in a lot of breaches. And, this is one of the first things you learn as a healthcare provider. Negligence is something that you strive to not perform. And obviously looking at the economic side, with the rising cost of healthcare to the point where some people can't even afford it, you have an increase in cost and more stress on the system where less people get the adequate care that they need, and inadvertently it goes into the patient's family's pockets, and they're paying more for something they feel like they didn't get out of. And this also ties into the violation of autonomy, where they can receive more unnecessary care that's not really needed in an attempt to, reconcile the damage that was done by not providing the initial treatment. And obviously, you have to think about, this is a very sensitive time for a lot of people's families. So if you're not giving them the proper end-of-life care, it may leave a lasting impression, and they might not be able to grieve it properly.
When planning for better end-of-life care, several key steps can make a meaningful difference. First, initiate early communication. It's important to have honest, timely conversations about the patient's goals, fears, and any final concerns, as well as their preferences for care. Next is developing an advanced care plan. This means making sure the patient's wishes are clearly documented through advance directives and healthcare proxies. It also involves clarifying their choices regarding resuscitation, ventilation, artificial nutrients, and other life-sustaining treatments. Early access to hospice services is also essential. Recognizing when curative treatment is no longer a viable option allows for timely referrals. This helps manage symptoms and ensures the patient's comfort and quality of life are supported. A strong interdisciplinary team approach is key. Collaboration between doctors, nurses, social workers, and other professionals ensure the physical, emotional, and spiritual needs of both the patient and their loved ones are addressed. Personalized care is just as important. End-of-life care should reflect the patient's values, cultural beliefs, and other personal definition of dignity. Every plan should respect the individual and their unique wishes. Lastly, we must remember to support family members and caregivers. Providing education, care, and grieving services can help ease the burden they carry. Counseling both before and after the patient's passing is essential to help them cope and heal. Together, these steps create a more compassionate, respectful, and patient-centered approach to end-of-life care.
I'm going to be discussing shared decision-making and patient and family hospice education. The first question that comes up is, whose job is it to educate patients and families about hospice? And that answer might be different. If a patient is readmitted, perhaps this is one of many recent readmissions into the hospital in the course of a chronic disease, the hospitalist may consult with palliative care, and palliative care may come and see the patient while the patient is admitted, and have that discussion then, which obviously then there are the hospital resources kind of at hand to help aid in that conversation, or the primary care physician or specialist that the patient sees when he or she is outpatient may be the one to bring up that conversation. And the next thing that we really need to talk about is, okay, what does that education for the patient and family entail? It's not just, hey, here, I want you to go see this other physician, which obviously can happen when we're referring out to other doctors or providers. Obviously, this is a different conversation than the patient and family have had with the physician before. In the course of the chronic disease, the expectations for treatment outcomes change at different times, and sometimes they're better, and then they can become worse and change back and forth depending on the course of the illness. But the most important information to provide to the family and the patient is, what does hospice look like for that patient? Obviously, that's going to be different for everyone each time, but one of the important things to address is, what kind of care will that patient be receiving while he or she is receiving hospice care? They will not be receiving curative care, but comfort measures look different for every patient. And many patients just think, okay, I'm going to be hooked up to a morphine drip, and that's it. Whereas that may not be the case for them or for their family at all. And this is truly a case of shared decision making. This patient needs all of the information, and the family needs all of the information, because much of hospice care does take place in the home. The family is going to be a major part of this transition, of this experience. And this is possibly the biggest decision. Therefore, the patient must be given all information that he or she can be given to help them understand the decision that they're making. The next extremely important question to address when discussing hospice education for patients and families are the myriad ways in which health disparities that have been present throughout the life course of a patient come to the fore when discussing end-of-life wishes and end-of-life care for patients. There are non-decision-based wishes pertaining to quality of life and decision-based wishes. The decision-based wishes have been defined by Johnson as wishes that are pertaining to medical interventions. And then there are non-decision-based wishes pertaining to quality of life. There have been shown lower documented rates for decision-based wishes for non-Hispanic Black patients than for non-Hispanic white patients. And this has shown a correlation with lower rates of hospice use by minority patients. Minority patients are also much less likely to be consulted by palliative care teams while hospitalized.